Well, good morning, everyone. Welcome. Sunday morning, bright and early, and we're here to talk about space medicine. There is no better way to start this morning's session than a direct illustration of the principles of telehealth and mentoring teletechnology. Right now we have a project that's taking place on Mount Everest. Dr. Christian Otto, Dr. Scott Parazynski, and a very large team are on Everest at various stages of ascent, doing a number of things, including assessing the effects of high-altitude physiology on human performance in the human body. So starting this morning, before the session, we have Dr. Christian Otto joining us live from Mount Everest. He has about a 7 to 10 minute presentation outlining the work that they're doing collaboratively with the Operational Space Medicine Program at the Canadian Space Agency, and how the work that we're able to do in this analog environment on Mount Everest is directly related to what we're going to be doing in space as we go forward and explore further. So we'll see if we can have the AV techs bring Christian up on the screen. Good evening, Christian.
Hi, Dave. Thanks very much for that introduction. And hello, Space Medicine Summit from Mount Everest. It's a real pleasure to be able to join you this morning by video. The Space Medicine Summit is a very important gathering, I think, for international space medicine collaboration and for the exchange of ideas on how to best prepare for upcoming missions of exploration. Exploration research is one of the main reasons I've been here on Mount Everest for the past 7 weeks. And I have several roles here. First and primary is as the research lead for the Canadian Mount Everest Medical Operations Expedition. And we have two main research thrusts. The first is exploration operational space medicine. And there are two components to this. The first is mission medical management with the Canadian Space Agency. And the second is tele-ultrasound guidance with Dr. Scott Dolchevsky. The second research thrust is high-altitude physiology, and we're looking at two aspects of high-altitude physiology: changes in pulmonary pressures with ascent as measured by echocardiography, while patients are either taking sildenafil, a pulmonary vasodilator, otherwise known as Viagra, or placebo. The second aspect of the high-altitude physiology we're looking at are changes in intracranial pressure with ascent to altitude by measuring the optic nerve sheath diameter and correlating it with acute mountain sickness scores. My second role here is as the expedition physician to a larger climbing team of 22 climbers. Already we've seen and treated a left hemispheric stroke, 2 cases of pneumonia, a dental abscess, a case of high-altitude pulmonary edema, and a second-degree burn, frostbite, and multiple cases of infectious diarrhea. Lastly, my third role, and an exciting one for me, is as a climber, and we've already completed our acclimatization, having slept at Camp 3 at 7,200 meters or 23,500 feet without supplemental oxygen. However, as I'd like to show you, even after 7 weeks on the mountain, my blood oxygen saturation here at 17,500 remains low. And if you can see the pulse ox, the upper number is my pulse oxygen, and it's running about 103, and my heart rate's 102. It's not normally that high, but perhaps I'm a bit nervous with the presentation. I'd like to expand a little bit on our exploration operational space medicine work. The first element is mission medical management in cooperation with the Canadian Space Agency. Now, since no single crew medical officer can be an expert in all content areas, the medical operations aspect to mission control will be an important aspect of mission medical care. At the Medical Operations Hub, multiple biomedical data inputs can be received, and tertiary consultant care can be coordinated, providing enhanced analysis and care, lessening mission impact in medical events. Initial integration of data occurs at the Medical Operations Center, which acts as the coordinating hub, if you will. Now, we've tried to mirror this process here on Mount Everest by linking with Dr. Jean-Marc Comtois and the Canadian Space Agency's Operational Space Medicine team at the CSA's Payload Teleoperations Center. And our pulmonary pressure echocardiogram research has served as the medical content. And I'd like to show you a little bit of that in just a moment. But from the CSA, we linked with the University of Ottawa Heart Institute and the chief of echocardiography. And interestingly, the Ontario Telemedicine Network provided the communications backbone. And all parties could view the Everest site and the ultrasound scanning, which allowed the CSA to follow the analysis. And the Heart Institute reported good visual detail in color Doppler, continuous wave Doppler, and pulse Doppler. The Echo Chief also provided, and most importantly, real-time guidance for an improved method of acquiring pulmonary jet pressures in our research project to the right ventricular window. And so what I'd like to do now is just show you two brief echocardiograms. Normally we could switch videos, but I'm just going to turn the computer so it faces the ultrasound, and perhaps you can see some of those images, and I'll give a commentary. So perhaps there you can see a still image right now, and it's a rather poor four-chamber view. And I'm just going to start the cine loop, and hopefully you can actually see some color flow, and that color flow is on the right side of the heart. And we're trying to measure pulmonary pressures via backflow across the tricuspid valve. And in this individual, there's not a lot of regurgitant flow, which should be seen as a bright blue jet at the inferior aspect of the mitral valve here. So hence it was very important to get that adjustment so that we could measure pulmonary pressures. Now I'm just going to change the view here and show you exactly what we were measuring. I tried to find a patient that had all the aspects we wanted to measure. And what you can see here are small deflections, which are, this is actually pulmonary jet pressures, and that is a measure of the backflow, which gives us an indication of the pressure in the lungs, which tends to increase as we ascend in altitude. Perhaps you can see it better with the cursor. Finally, I'd like to show you one more image. And I'm just going to explain a little bit about this image you're viewing here. During the session with the CSA, we described the stroke case that we had that actually occurred that morning, and the measurement of optic nerve sheath diameter, which actually revealed an increased left-sided intracranial pressure. Normally, the optic nerve sheath should be 5.2 millimeters or less. In this individual who had a right hemiparesis and likely a left hemispheric stroke, a 3-day history of left-sided headache, actually had a measurement of 4.7 millimeters on the right and a significantly increased measurement of 5.8 on the left. So what I'd like to show you now, this is actually an ultrasound view of the eyeball, the cornea, and this is the lens. That's important to have for a correct measurement of the optic nerve sheath. And this dark line here is the optic nerve sheath. And this is what is measured to assess the increase in that diameter. Now, the cerebral spinal fluid that surrounds the brain communicates with this optic nerve sheath. And in this case, it's 2.9 millimeters, which is quite normal. Finally, the second aspect of our exploration operational space medicine research is remote teleultrasound guidance with Dr. Scott Delchevsky, who I'm sure most of you know. And in fact, on Friday, we completed our second successful session with Dr. Delchevsky, direct an ultrasound naive subject to acquire clinically diagnostic pulmonary images. So to summarize, I think that exploration operational space medicine will play a very prominent role in upcoming long-duration missions. In addition, although we have focused on real-time applications, I believe asynchronous video communications has a value greater than we currently appreciate. With that, I'd like to end there and open it up to questions if we have time. Thank you very much.
Thank you very much, Christian. We definitely have time for questions, and what we'll do is we'll have members of the audience ask the question. I will repeat the question so that you can hear it, Christian, then we'll give you a minute or so to answer. Oh, okay. From what I understand, we have you real time on our mic that we're handing around the room, so you'll be able to hear it direct from the person asking the question. So let's go ahead and see if anyone has any questions for Dr. Otto. Yep, up in the back. Christian, while we're waiting for the mic to get up to the back, we're all very impressed with your ability to give a presentation like this at high altitude and continually speaking without having to take a few breaths. Very impressive.
Thanks, Dave. I'm sure it's the low frame rate. You couldn't see my hyperventilation.
Christian, this is David Dinges. Congratulations on a remarkable achievement here to everyone involved with this Canadian mission. Can you say anything about assessment of cognitive functions or performance? Are you doing any measurements like that? And have you noticed anything terribly dramatic living at high altitude?
Yeah, that's a very good question, David, and thanks very much for your well wishes. As you know, high altitude has a significant effect on cerebral function, particularly profound hypoxia. And certainly amongst the climbers and ourselves, we notice that our thinking isn't quite as crisp as we ascend to altitude. As I mentioned, we've ascended to 7,200 meters. And in fact, tomorrow, early in the morning at 4 a.m., we start our 5-day summit push to the summit. So hopefully the weather will be on our side. As you know, there is a NASA group here doing some work on, I believe, aspects of team collaboration. But it's well known in the high altitude research community, the effects of high altitude on cognitive function. And in fact, Dr. Peter Hackett from Colorado has done some cutting-edge investigations using MRI, looking at high-altitude mountaineers who climb without oxygen, and he's actually found cerebral atrophy. So there is quite a profound effect, and in fact, we'll start climbing with supplemental oxygen at Camp 3.
Any other questions for Dr. Otto?
Yeah, Christian, this is Richard Jennings. You're one of the few people who's provided medical care at both Antarctica and now on Everest. How would you compare the two environments for a spaceflight analog?
Well, that's a really interesting question, Dr. Jennings. What I found, personally, I think that they perhaps both have roles to play. I think Antarctica is probably a greater analog in terms of science that occurs, the remoteness of the environment, and the duration. That being said, I found the conditions here on Mount Everest to be perhaps the most austere I've ever encountered. We've been here nearly 2 months. It's very, very harsh living. We've been living in small expedition tents. It's not, despite what you might have seen or think, base camp is actually a rock quarry on top of a glacial moraine, so it's very difficult walking around. Toileting, dining, and showering facilities are very crude. So I think for short, perhaps intense training elements, expedition type of environments such as this may have a role to play, but I think for the longer duration missions, Antarctic research stations are perhaps a closer analog.
Excellent. Thanks, Christian. Dave Wolf has a question for you.
Hello. How cold is it out there right now? That's not my question.
Well, yeah, Dave, it's gotten a lot warmer over the past 6 weeks. Things are melting quite a bit. Right now, I've got the heater on in the medical tent here. It's probably going to get down to about -5 this evening, but when we first got here, April 9th, it was getting down to -15 degrees Celsius. Certainly, though, up high, Camp 3 at 23,000 feet, it's -15, and on summit day, we anticipate temperatures of approximately -25, and it's warming up quite quickly. If we'd been on a summit push 10 days to 2 weeks earlier, it'd be in the -30s.
You look good, but a bit haggard. Take care of yourself. Here's my question. If you would like a more lucid moment of clarity or higher performance and you take some oxygen, at what point do you think you'd be backtracking, defeating your adaptation?
I'm sorry, I didn't hear all of the question. Is it possible you or Dr. Williams could repeat it?
Yeah, maybe I wasn't in the mic good. If you would like a period of higher performance or clarity of thinking and you go on oxygen for a while, how long do you think until it would backtrack or defeat your adaptation to altitude? You know, minutes, hours, days, weeks. Any sense for that?
Well, I see what you. Yeah. That's a good question. At our first climb to Camp 3, we slept at Camp 3 without oxygen to really push our acclimatization. That was our third time up the mountain, and we will start using oxygen. And we use 1 liter to sleep at night, and that will effectively put you down approximately 1,000 meters. When we're climbing up to the col, we'll be climbing on 2 liters per minute, and then when we climb to the summit, 2.5 to 3 liters, definitely 3 liters on the Hillary step. We'll be on oxygen for probably 3 days, so we don't anticipate that will affect our acclimatization over the past 6 weeks. As you know, there's a chronic acclimatization, significant humoral factors, red blood cell production, shifts in the oxyhemoglobin dissociation curve, etc. So it's definitely a performance enhancer, and we don't anticipate it affecting our acclimatization.
Thanks.
Thanks very much, Christian. When you see Scott, give him our best and best wishes to you and your team. You're doing a fantastic job, and I think truly what you and Scott and the rest of the team are doing on Mount Everest represents the next generation of medical explorers, taking us farther here on Earth and certainly being able to take us farther into space. Best wishes for the remainder of your mission. Great job, and thanks very, very much for joining us this morning.
Thanks very much, everyone. Thanks for having me. It was a pleasure. Good luck with the rest of the conference.
Absolutely outstanding.